in terms of the involvement or otherwise of the colorectal fascia. We talk of a positive if it is either breached or the end point of the tumor is less than a millimeter from the fascia. That will be, so when you see the report MRF positive, that is what it means, and it has something to do with the circumferential dissection margins that you try to achieve in surgery. For T4 tumors, T4B, they will involve the organs. So it involves, invading the prostate. If it involves the skeletal muscle, that is the external sphincter, it becomes a stage 4B. That's agreed. Otherwise, if it's limited to the internal or has not gone beyond the sphincteric space, it is a 2. So that is critical. So that when you're preparing for either sphincter sparing procedure, and especially for low rectal tumors, if we have not mentioned that, it's always good to you can also liaise with the reporting radiologist to be able to give you that information. So this one has extended to the fascia, beyond the fascia. Additional part of the reporting of the T is what I was talking about, involvement of the pelvic floor and the suicide invasion. You can clearly see the anatomy, especially when you get a proper oblique. The anatomy comes out very well. You can clearly see the external, the internal, systemic space, and the region is basically confined within that, and the invasion of the external on the right side. So those are the sort of details that we are able to pick from these images. One other critical aspect of what we look for is extramural vascular invasion. Basically, we are talking of contiguous extension of the lesion into a vessel. It tends to be nodular. Sometimes you may see a prominent vessel. If it's not nodular, if it's not, we are not seeing a signal similar to the lesion, it may not necessarily mean, that there is a EMVI or extramural vascular invasion. The other important part of that is the step 5, is the end stage, and what you are interested in is the different stations of lymph nodes. We have the ones within the mesorectal fascia, the mesorectal nodes. This extension is important. Many a times you will get the reports, and sometimes we may not have given you this. It is important to always, from the report, for completeness, ensure that somebody has said what is the highest station involved, so that for surgery, for surgical purposes, or for radiation, you are able to take care of that. Otherwise, they tend to be the points of recurrence, source of recurrence. So the different groups, the mesorectal, the internal iliac, the obturator, and the external iliac, depending on, we use these criteria, either is it as an N1, N2, and not all nodes, small nodes will actually be free of tumor. We use other characteristics, the borders and the heterogeneity of the signal within the node to say, is it suspicious? And if suspicious, we'll always point out this so that we can arrive at the exact N for that matter. This currently we are using the TNM staging, and this is a summary of the same. So what we are saying is that sometimes the extra mesorectal nodes, like the obturator ones, because normally you don't remove them when you are doing the surgery. So it's important to capture that aspect for our radiology colleagues, so that if it's suspicious, because more often than not, those tend to be the origins of of recurrence. For our oncology colleagues, they need to know that, so that when they are planning, they can include that for purposes of radiation. Sometimes we get deposits, and we normally consider them under the end stage. These are not, they look like nodes, but they are not nodes. So and the other step is, of course, you look at everything else. You have a pelvis by and large, so there may be other issues, maybe in the bladder, fibroids or whatever, in the other organs involved. So that is also part of what you include in the reports. Then the M stage, basically you are talking of metastasis, either to one organ or without peritoneal or with peritoneal metastasis, or beyond the peritoneum. For restaging after neoadjuvant therapy, we follow more or less the same steps. It's only that now in this case, we talk of the response, whether is there near complete or possible complete response, intermediate or poor response. And sometimes we give the Y to indicate that we are looking at resurrected fascia after some intervention. So the final stage, when you see that, means that there has been some intervention. And that normally is the assessment that we should normally get at the end. So the diffusion weighted imaging, we tend to use it more when we are talking about restaging or rescanning for patients who are either mid-cycle or at the end of the treatment. Limitations, fibrosis versus residual tumor in terms of differentiation. The newer machines will have newer sequences like the diffusion rate of imaging. We also do post-GADO studies to try to differentiate the fibrosis and residual tumors. The only challenge is that as a limitation, this tends to be operator dependent in terms of interpretation, and that is where the issue of MDT comes in. What have you picked clinically? So as part of the conclusion, let me say that MRI is an essential tool for staging, planning, and post-treatment assessment. We are lucky that we have 3 Tesla in the institution. We have 1.5 Tesla in the institution. As an imaging team, we are there to support you with the imaging requirements that you may have. Thank you.
Okay, we thank you, Dr. Liga, for that presentation. We welcome the new people who are joining us. And we apologize a bit because we have a small hitch, but we'll be rejoining the bigger hall because I think they are finished using. But I think the best time is during the tea break. I think you can see Dr. Dego at the back, who is my mentor. You're welcome, Doc, as well. The next presenter will be Dr. Fiona Anyumba. She's one of us. She's a vascular and interventional radiologist. She's just back from her fellowship, and we welcome her back. She's a graduate of the University of Nairobi, the University of Pisa, and just finished her fellowship in interventional radiology from the University of Toronto. She's passionate about interventional radiology in oncology. So she will talk to us about the role of interventional radiology in recurrent and metastatic colorectal cancer. Please note your questions, then at the end of it, you can have Q&A for the panel. We still encourage our presenters to keep time. And I think Dr. Mukuli will share the slides at the end. So don't worry about it.
Okay, good morning. I hope you can all hear me. So my name is Fiona. Thank you, Dr. Kibucha, for the very warm introduction. And thank you for the opportunity to present on the role of IR in the management of colorectal cancer. Is it possible to... Okay. All right. So as an overview, I'll introduce the role of IR, discuss the role of biopsy in metastatic lesions, the role of IR in the management of complications related to colorectal cancer, and its role in the treatment of metastatic disease. So IR plays a significant role in the management of colorectal cancer, as it offers minimally invasive techniques that can be used as alternatives to surgery or as adjuncts to other treatments for both curative and palliative purposes. The most common use application of IR in colorectal cancer is the percutaneous biopsy of metastatic lesions, and this involves sampling of tumor tissue from a suspected metastasis in the liver or other locations, and is typically performed using a needle inserted through the skin under imaging guidance. It's useful in confirming the diagnosis of metastasis, differentiating metastasis from other liver lesions, treatment planning, and monitoring treatment response. So this is just an image of an example of a segment, I'd call it 5-8 liver lesion that was suspected to be colorectal cancer metastasis. So this is its visualization on CT, the same on ultrasound, and then this is an image of the biopsy being taken. And as a principle, you should always visualize the entire needle, and you should see the needle going through the lesion as you take the biopsy itself. This is a lung biopsy for a patient who had mass